Thank you, Chairman. Thank you, Dr. Mohan and his team. Dear friends, I think a very important topic that how do you prevent osteoporosis in the elderly, especially with diabetes. You see, osteoporosis is a chronic progressive disease, which causes fragile bones, fractures. Not only that, severe pain. So the elderly people come with the pain of the bones. You think the patient has an osteoporosis. And osteoporosis in elderly, it's not like your graying hair. You can't prevent graying hair. You can't prevent wrinkling of your skin, but you can definitely prevent osteoporosis. You could really have a lifestyle changes, exercises, medications that can definitely prevent or even help to retard the progression of the osteoporosis. The risk factors for osteoporosis is the age. People get older, they become, the female sexes are the most culprits. They have the osteoporosis. People have low BMI, longer duration of diabetes, and the type 2 DM always leads to decreased bone turnover. I'll tell you how exactly the mechanism of action of the hyperglycemia on the bone. Sometimes the BMD may be normal in diabetics, but they have a impaired bone quality. Look at the slide. The hyperglycemia, it causes increased levels of a substance called the sclerostin. That's a protein produced by the osteocytes that inhibits the bone formation. So it causes low bone turnover and osteoporosis and fragility. When we talk about the therapy, now we have beautiful drugs to address the sclerostin. We can prevent the formation of sclerostin in the diabetics. Now look at the scenario here. The prevalence is very high in diabetics, almost double than the normal population. The osteoporosis prevalence is 3.13 in the general population, whereas in diabetic population is 6.10, and women are more affected. See, 44.8 versus the men with type 2 DM with the 37%. Now the drugs, as we addressed, I think Kumar mentioned that we have some drugs to cause the osteoporosis, fractures. Metformin is neutral and beneficial. We can definitely use it. Insulin is not, it's very good for the bones, but sometimes you give aggressive insulin therapy, the patient may go over a fall in hypoglycemia. Not pioglitazone. I always pay very careful on the post-menopausal women, not to prescribe the drug called the pioglitazone. SGLT inhibitors, the canagliflozin has shown increased risk of bone fractures. The GLP-1s are safer. DPP-4s are bone safe. So remember these drugs when you prescribe the prescription for diabetics. Insulin does not worsen osteoporosis. In fact, it helps the protective effect on the bone health. Osteoporosis in women, 61 million people are there currently in India. 80% are women. I think a lot of girls here must be very, very careful in the future that you should not go for osteoporosis. The peak incidence occurs like any disease in India 10 to 20 years before. A beautiful classification. See, primary osteoporosis, secondary osteoporosis. Primary is type 1 postmenopausal, type 2 senile. So elderly women belongs to both type 1 and type 2. Secondary, we have multiple causes, risk factors. I'll list these are the medical causes where the patients have secondary osteoporosis. Look at the number of medical conditions: malabsorption syndromes, rheumatoid arthritis, chronic kidney disease, endocrine disorders. Medications, number of medications: corticosteroids, anticonvulsants, especially very, very important, pioglitazone, heparin. We have number of drugs which causes severe osteoporosis. Modifiable and non-modifiable risk factors for osteoporosis. Non-modifiable is the age and the gender, female. It's a curse for women to have osteoporosis, race and ethnicity, but modifiable is there. You have a good nutrition, good calcium and vitamin D intake, good physical activity. I think last slide I'm going to show you the importance of exercise in people to prevent the osteoporosis. This is how it presents. Patients can have a decreased body height, postural changes, shortness of breath because of the movement of the chest is impaired, multiple fractures, movement disability. Very simple test in your patients to say how to have a osteoporosis, the wall to occiput. Normally it's 0. Anything more than 0 that you suspect osteoporosis. One of my patients came last week, very young fellow, he's not very old, he's only about 47 years old, Look at the amount of hyphos he has got. The Walt oxybut test is so much positive. He's a diabetic, alcoholic, already had a bypass surgery, severe osteoporosis. Look at the fractures now he has got. Number of fractures in the dorsal vertebrae. Another test is women who have a rib to pelvis distance. Negative test is more than 4 fingers. If you have a distance between the rib and the pelvis is less than 2 fingers, then the patient has got probably a old fracture of the lumbar vertebrae. Menopause, diabetes, osteoporosis. Postmenopausal women with diabetes, particularly type 2 DM, have faced increased risk of osteoporosis. All women suffer from severe bone loss in the immediate postmenopausal state for 4 to 5 years. This is a crucial time for intervention. If you don't intervene, you can never modify the osteoporosis which is set in. So very important postmenopausal women, please take care that your bone is intact for initial 4 to 5 years time. Fragility fractures, look at the fractures, hip fractures, vertebral fractures, wrist, they are common in order occur in osteoporosis. When you assess the screening for these people, all Western guidelines says women more than 65 years old, men more than 70 years old. But in India, I would always say that we should definitely assess the patients almost 20 years before. So you should assess women when they are 45 and men at 55 years old. Laboratory investigations, you could see all older patients should have a normal calcium level, 25 hydroxyvitamin D3 levels, and PTH assessment. Definitely the special group, like we suspect the secondary osteoporosis, they must have a special investigations, like what I mentioned there. The bone density, mineral density is available everywhere in India. Everywhere in Chennai, you can get it for about 600 rupees. And this is also called as the number of terms, BMD scan, bone densitometry, DEXA bone scan, and things like that. Very easily can be done. It also gives the bone symmetry, the fat mass. If you want to see, your muscle mass also can be assessed in the DEXA bone scan. This is the T-score interpretation of the DEXA bone scan. Look at the right-hand side. The T-score becomes minus 2.5. Your bones is similar to that. There's so much of osteoporosis. That's a T-score. When you have a T-score less than, the normal is less than 1. If you have osteopenia, it is less than minus 5 to minus 2.5. If you have more than minus 2.5, it is osteoporosis. You must know that they give T-score and Z-score in the DEXA bone scan. T-score is comparing the age group of the patient with the age of 30-year-old woman. Z-score, the same age, same ethnicity. If you are 70 years, they compared to the 70 years old. So look at both the T-score and the Z-score in the DEXA bone scan. You can also have an assessment through your internet, the fracture risk assessment tool. It's very important that this has to be done in patients before you start the therapy. How much is the fracture risk score? The normal fracture score is less than 10% is getting a fracture risk of less than 20% in the next 10 years, or getting a hip fractures less than 3% in the next 10 years. Trabecular bone score also can be done by the machine says that the TBS value is 1.350 considered as normal. Now the National Orthopedic Foundation guidelines says that the T-score of minus 2.5 in a lumbar spine, you should start treatment. But the patient's got intermediate, minus 1 to minus 2.5, you also assess the fracture score before you start the treatment. This is the treatment guideline by the National Osteoporosis Foundation. And the calcium supplementation, a lot of people have a doubt. 50 to 70, you should consume minimum 1 gram a day. People women more than 51, less than men more than 71 should consume 1,200 milligrams, not more than that. More than that will cause a lot of problems in both elderly people. But imagine your dietary calcium is already, if you are taking a good diet, it is almost 600 to 700. So the rest has to be given by oral route. And the calcium citrate is more important because it doesn't need hydrochloric acid, which is much less in elderly people. Vitamin D supplementation, I think everybody knows that when people come to the clinic, when I check the vitamin D, so many deficient people are there. Most of them have a very, very low vitamin D3, less than 10 is insufficient, 10 to 30 is okay. Anything more than 10 to 30 is insufficient, more than 30 to 100 is good, above 100 is harm. So the people who got a chronic renal insufficiency, patients who are on some medications and have a very, very severe vitamin D deficiency. And vitamin D supplementation has to be given. see, 600 IU for people less than 70 years, 800 IU for people more than 70 years old, and the people with more than 50, less than 70 can have a 600 to 1000 IU, but nothing like your natural you be in the sun. And patients receiving for treatment for osteoporosis are offered concomitant calcium and are giving vitamin D therapy. Vitamin D sufficient. I said the patients are extremely deficient. You can give a weekly therapy of 60,000 units, maybe for 4 to 6 weeks, reassess the vitamin D levels, and then look at the prescriptions. Can vitamin D reverse osteoporosis? Osteoporosis is not reversible. It should prevent. It's not reversible. Taking calcium and vitamin D help to reduce the potential complications of fractures. Beautiful slide shows you the drugs available for osteoporosis. These drugs act on the osteoclast. Most of the drugs act on the osteoclast. Osteoclast, which removes the bone, the dead bone, the older bones. Osteoblast, which constructs the bones. All these biphosphonates, bisphosphonates, hormone replacement therapy, estrogen, raloxifene, the denosumab, calcitonin, they all act on the osteoclast. Whereas the recombinant parathyroid hormone available for the injections, it constructs the bone by promoting osteoblasts. So a number of pharmacological agents. The first line drug is bisphosphonates. So bisphosphonates, not people who have got a CKD less than 30 ml of EGFR. We have oral bisphosphonates. We have the daily, weekly, monthly drugs. Intravenous is very popular. Intravenous, I normally give to all my patients zoledronic acid minimum for 3 years, yearly once. And patient cannot tolerate the bisphosphonates orally, because the orally drug has to be taken and then patient has to sit, then wait for about 45 minutes. It can cause severe GERD and esophagitis. Mechanism of the bisphosphonates are very, very excellent. It's an osteoclast poison. The bisphosphonates, when you give it, it goes and coats the bones, the surface of the bones. So osteoclasts, when they come and remove the bone, they eat the bisphosphonates and they die. So that's action. So you give yearly once bisphosphonates, patient have a prolonged effect of preventing the fractures for another 1 year. The side effect is, look at the elderly people who have atrial fibrillation, and sometimes it can cause the osteonecrosis of the jaw. I'm using it for the past 10, 15 years, yet to see a patient with a jaw. This is the drug which is given intravenously monthly once. Yearly once. Hormone replacement therapy were not for the women above the age of 60, but immediate postmenopausal period you can give. But look at the complications of the hormone therapy, like the breast cancer or people with the CVD, people with the venous thrombotic embolisms don't give. It's a good exchange for the estrogen, the raloxifene. It's a estrogen agonist actions in the antagonist actions on the breast and the endometrium. So very safely can be given. It can be given orally 60 milligrams. The one complication is that the patient can have a deep venous thrombosis. So check the D dimer when the patient is on raloxifene. All women candidates. We have the beautiful new drug called the basidoxifene, which is much more safer than the raloxifene. Teriparatide, I use it extensively in my practice. Extremely painful conditions they come. You give the teriparatide every day, 20 micrograms. The patient have a beautiful improvement from the pain. This drug acts on the osteoblast, the teriparatide. So we have to give it for minimum 2 to 3 years time. And the teriparatide is a PTH analog. And when you come to the calcitonin spray, people cannot tolerate the bisphosphonates. People cannot tolerate the raloxifene. Then you can give them calcitonin spray. The spray is very good because the minute you start it, the bone pain disappears. The bone pain disappears. And you can definitely use it in patients who have an options. And the patient should be at least minimally for 5 years in the postmenopausal period. Denosumab is an excellent injection. It's a monoclonal antibody which is useful in the metastatic bone pain, inhibits the rankle protein, the osteoclast. Beautiful drug. You have to give only once in 6 months time. 2 injections per year. You give all your cancer patients who have metastasis in the bone. This drug acts very well, and then they get a very good relief. The beauty is you can combine these drugs we can combine these drugs. We can give both bisphosphonates, and we can also give the injectable teriparatide. The romosozumab is the one which I said. This is the one drug approved for diabetics with osteoporosis because it blocks the sclerostin production in the osteocytes. So one drug which is very, very good is only given to be 210 milligrams subcutaneously monthly once, not available in India yet. Treatment duration, not more than 5 years because the drugs are toxic. And which fruit is important for, I think, nutrition specialists to be here. I always tell my patients, murungakkeera, agathikkeera, madakathangeera, attipadam. So anyone, they can take it. So these fruits are very, very good to prevent the osteoporosis. 5 medium fresh bigs. People should not buy the one from the Dubai. This is our local figs. Bananas are very good for preventing osteoporosis. Only thing, they have a potassium-calcium exchange in the osteoclast. But diabetics, they cannot take the bananas. Nuts are very, very good. 25 grams of nuts for all diabetic patients prevents the not only lipid profile friendly, they also have excellent friends with your almonds and sunflower seeds and pistachios, prevents the osteoporosis and improves the bone health. So prevention of osteoporosis for seniors with or without diabetes, modify all secondary causes of osteoporosis, adequate calcium and vitamin D intake, regular weight-bearing, muscle strengthening exercises, prevent falls, correct vision and hearing, evaluate gait and balance, assess the medication side effects, evaluate the home safety, and hip protectors if the fall risk is very high, quit smoking and limit or avoid alcohol and caffeine. So these are 3 types of exercise available: weight bearing and the resistance and the flexibility exercises. Weight bearing activities, nothing less. You have walking or a dancing or a low impact aerobics, elliptical training machines and stair climbing and the gardening. The exercise like your weight bearing and the muscle strengthening, they improve your muscles. When you keep your muscles intact, prevent sarcopenia. So that prevents the osteoporosis. That's one of the very important lessons I thought I'd tell you. These are very, very simple exercises you teach your elderly people in your clinic. Simple exercises, available all in the net. Simple, about 15, 20 minutes a day. They can sit and do the exercises. Number of wide leg squats, standing leg curl, knee extensions. Small, simple exercises in the seniors prevents the osteoporosis. Can walking reverse osteoporosis? Osteoporosis, I said, not reversible. Preventable. So don't develop osteoporosis, but medications, a nutrition-dense diet, weight-bearing exercise can help and prevent the further bone loss and rebuild bones. I'm going to show you a video. He's a 76-year-old senior. He's a physician, a doctor, doing an exercise. See? So age is no bar for doing an exercise. You can have your own muscles. You can have a good, healthy frame of your body. So always see that age is not a number for preventing doing an exercise. Walking, anybody can do, but some of the muscle strengthening exercises, I always, my friend Shanmu always says, you taught me exercise, now I am feeling much better. Because this also keeps your receptors very well. Sarcopenia, Korean people say sarcopenic diabetes. One of the very important things that when you lose the receptors, you become a diabetic. Hip protectors, I told you, the affluent seniors can wear hip protectors. And the prevention of falls, put a good light in the bathrooms, ventilators, and non-skid soles, non-slip mats. I think we have railings on everywhere. When the senior persons get up and then go for the thing, put a railing everywhere. Keep a flashlight on the bedside. I think the simple tips is that eat foods that support the bone health, get enough calcium, vitamin D, and protein for each day, get active. Choose weight-bearing exercise such as strength training, walking, hiking, jogging, climbing stairs. Maybe you can play tennis and dancing. Don't smoke. Limit alcohol consumption. This is the carry-on message. I think I already told you the number of things. I think we have future, a lot of drugs are coming, but nothing like your own good nutrition, nothing like your own good exercise, which is going to prevent osteoporosis, prevent falls. If a senior person gets a fall, looking after him in the house is so difficult. The women, they don't look after. Some people are not cared for. So prevent osteoporosis, prevent fractures, prevent pain-free walking for the elderly people. Thank you very much. Thank you.